I'm going to talk on this very common topic, which I'm sure all of you see from time to time. We know that COPD is a leading cause of death. It's going to be third leading cause of death expected in 2020. Almost 14 million patients in India have COPD out of the 94 million smokers. So it's a large burden basically, and almost 10 lakh Indians die of smoking related disease every year. When the patient comes to you in the either as a exacerbation either in the OPD or in the emergency ward, there are many questions which come to your mind, and you need to answer each one of them to decide how you're going to treat them. First question obviously is it COPD? Because if you have the wrong diagnosis, patient had acute pulmonary edema, then you're going to go on the wrong line. So obviously you need to decide, starting from the first question, is it COPD? Is the patient in acute exacerbation? Where should this patient be admitted? Should this patient be treated at home, or should this patient come to the hospital? Do I need to give antibiotics? Do I need to use bronchodilator in this patient? Do I need to use steroids? So there are many questions which we need to answer in these patients. So the first question is, when the patient comes to you, is it COPD? Now I'll just give you an example which you see many times. 68-year-old male who's a ex-smoker, 80-pack years, so clearly a very heavy smoker. Diabetic who's on insulin, not very well controlled, presents to emergency ward with 1 day history of worsening of shortness of breath, increasing purulence of sputum, though the volume has not increased, slight chest pain on left side, and increasing cough. On examination, he is found to be febrile. He has a pulse of 120 per minute. His blood pressure is 96/60, which is kind of borderline, and saturation on room air is 88%, so he's clearly hypoxic. He has a respiratory rate of 26 per minute. His chest has got bilateral wheeze, and after seeing this patient, the resident decides to order respective investigations like CBC, renal function test, LFT, blood cultures, chest X-ray, and EKG. Now clearly in this patient, if you look at the patient, he's a smoker, so obviously chances of having COPD with wheeze and a history of shortness of 1 day becomes like COPD. But what we don't know in this patient is, what it hasn't been mentioned is, how long this patient has been suffering from this kind of disease. Is it something acute, or has he had this disease for a long time? Now you need to remember that only 15% of all smokers will have COPD. So just because he was a smoker does not mean that he has COPD. So you need to have a good history to decide. And to be certain of the diagnosis, if you take the gold guidelines, you would say that the person has to have chronic respiratory symptoms. So in this patient, the last patient which we just said, has to have symptoms going on for many, many years. And they have to be respiratory symptoms like shortness of breath, chronic increased production of sputum, and some other symptoms basically. Plus he should have incomplete reversible airflow obstruction, which is FEV1 by FVC has to be less than 70%. And the FEV1 should be less than 80%. Now some of the patients who have FEV1 less than 80% and they are mild, if you look at the classification, may not actually have any respiratory symptoms. But if you've done a PFT in these patients as a screening test, which happens in medical health checkups, then you can actually catch these patients very early. And also it is important to realize what is the degree of severity as a stable COPD, simply because a patient who was in stage 1, if he has an acute exacerbation, he can sound like stage 4, but if a stable patient of stage 4 is there, if you didn't know the history, you would feel that this patient is actually in acute exacerbation, whereas that may be his stable phase. So you need to really know exactly as to what stage this patient was in prior to presenting to the emergency ward. And you can see that the important factor is FEV1. If it is less than 50%, then most of these patients will have respiratory symptoms. They will be hypoxic. If it is less than 30%, chances are that the person will start to retain carbon dioxide but be clearly hypoxic, and it will affect his daily life of living basically. So you can see the stage 4 is very severe COPD, which is less than FEV1, less than 30%, and the quality of life in these patients is appreciably altered, and exacerbation may be life-threatening. And the only symptoms in these patients can be alteration in mentation. Everything else may be the same, but only the mentation are altered. They get more confused, they are more obtunded, and that may be the only feature of acute exacerbation in these patients. When you do spirometry in these patients, frankly speaking, it does not really tell you about the debility. I'm sure all of you must have seen patients of FEV less than 50% but can still walk for almost 3 to 4 kilometers without having any symptoms. But it does tell you what is the, if you take the activity of daily life and the severity of the spirometry, it does give you a rough idea of what is happening to the patient. The reversibility does not tell you whether this patient will respond to steroids or whether it does respond to bronchodilators. So reversibility is not a must in these patients. And you need to remember that a COPD patient may have other diseases also. So you need to remember that this patient may have other things, but the most common differential diagnosis with COPD remains asthma. And it is important to distinguish COPD from asthma simply because asthmatic patients tend to do better even at the chronic stage as compared to chronic COPD in stage 4, who tends to be much more worse as compared to chronic severe asthma. And the differentiation is very clear that COPD will present to you from the mid-age to elderly age after having smoked for many, many years, though in some patients, especially in our country, you may have history of chula smoking or exposure to noxious stimuli. These patients in asthma are normally non-smoker. The cough and phlegm production is very less. Dyspnea on effort is variable. Wherever the COPD patient will tell you very clearly that he's been dyspneic for many years and recently the dyspnea has increased. Whereas in asthma it's episodic. If he's fine in between, he may not have any symptoms at all. The diurnal variation is hardly ever seen in COPD, where it is a very common symptom in asthma. And these patients of asthma tend to respond very nicely to steroids as compared to COPD, where the response may not be as good. So when you see a patient, is he an acute exacerbation? So what is an acute exacerbation? Frankly speaking, any event which causes the disease to alter in terms of either increase in dyspnea or increase in cough or sputum production, which is beyond day-to-day variation. And it is acute in onset. This happens suddenly, and that may warrant some kind of change in the sense that he may have to drugs, he may have to take antibiotics, and certainly the patient presents to the emergency ward. So if there is any change from day to day, which means that let's say stage 4 may be breathless at all points, he may have peripheral edema at all points, but he is not an acute exacerbation until unless certainly he has more symptoms of, let's say, increased purulence, or he becomes altered in mentation and he comes to the emergency ward. So you need to remember that these things are very, very important. This is a UK study where it showed that out of 1,400 admissions, when they looked at it retrospectively, they found that 34% patients were readmitted, and out of which 14% actually died within 3 months. It's got a high mortality. When you look at the symptoms of exacerbation, the 3 cardinal symptoms are increased dyspnea, increased sputum purulence, and increased sputum volume. These 3 are the most important, which actually makes you decide as to what you're going to do with these patients most of the time. But obviously the other symptoms like increased cough, increased wheeze, increased upper airway symptoms, reduced exercise tolerance, fluid retention, increased fatigue, and acute confusion may also be there in different phases of COPD. If you have fever and chest pain, frankly speaking, it should prompt you to look for other diagnosis or maybe associated diagnosis with COPD exacerbation. And these are: patient may have actually pneumonia, patient may have pneumothorax, patient may have pulmonary embolism, congestive cardiac failure, respiration, lung cancer, pleural effusion, because all these things happen in the same age group of patients as a COPD patient has. And also, they're all related to either smoking or otherwise. There are certain features of severe exacerbation which should alert you to decide whether this patient will be admitted to the hospital and probably come to ICU, which is marked dyspnea, tachypnea, if you have pursed lip breathing, if you are using accessory muscles of respiration, if you have acute confusion, if there is a new onset asthma, cyanosis, or if there is peripheral edema. So should this patient be admitted? Now, frankly speaking, most of these patients can actually come to you in the OPD and they can be managed at home. Until unless you find that you need to give them nebulizer or you need to give them extra oxygen, or when you feel that they need to have certain additional things like non-invasive ventilation, or maybe they need to have intravenous antibiotics. Otherwise, most of these patients can be treated at home. So presence of comorbidities. If the patient has had a long-term oxygen therapy at home, if there have been previous admissions, and if he was not able to cope at home, would be clear indication for admission. And you can see in this chart that if you have if you have very severe breathlessness, if your general condition is deteriorating, if you're confined to the bed, if you have cyanosis, if you have worsening peripheral edema, if your level of consciousness is impaired, if you're already receiving oxygen therapy, social circumstances, if you're living alone, which means that anything can happen to you in the middle of the night and there's nobody to look after you, probably you need to come to the hospital. And acute confusion, if it is rapid onset, within last 1 day, you need to come to the hospital. If the saturation is very low, if there are changes on the chest radiograph, so all these factors will make you decide whether this patient will come to the hospital or whether this patient can be treated at home. So when he comes to the hospital, you need to decide, query, can it be treated in the ward or can he be sent to the ICU, which means that you need to be very clear. So if you have a change in mental status, clearly it tells you that this patient should go to ICU. If you've treated the patient in the emergency ward and the patient is not showing any response or the response is inadequate, clearly this patient needs to go to ICU. If there is worsening hypoxemia and hypercapnia, clearly initially he may be treated in SDU, but he needs to go to ICU. If there is a need for invasive ventilation or if the patient is hypotensive, clearly an unstable patient cannot be treated in the ward and needs to go to ICU. So when you examine these patients, obviously you're going to do certain tests. Chest X-ray will be helpful to tell you whether there is a patch of pneumonia, whether there's any comorbidities like enlarged heart or pneumothorax. Blood gases obviously are very, very important in these patients because they tell you the degree of severity of hypoxemia and as well as hypercapnia. ECG to tell you whether this patient has had something else. You obviously need to do a full blood count to look at infection indices. You need to do urea and creatinine because this is part of the curve syndrome. If you have a pneumonia in COPD patients, again you need to decide based on curve criteria whether this patient needs to be admitted to a particular place. If the patient has been on theophylline drugs, then you ideally should send a theophylline level. And if the sputum is purulent, especially with fever, then you must do a sputum culture. Though sputum culture in a mild exacerbation may not always be a must. And the blood culture should always be taken if the patient is pyrexial. So once you've decided that this patient has got COPD and he's pyrexial and he's got all these things, you start the treatment, and the main treatment obviously is combination of bronchodilators, antibiotics and steroids. So what does bronchodilator do in these patients? They actually improve lung emptying. If you do the FEV1, unlike asthma where the FEV1 almost immediately improves, the FEV1 does not improve in COPD. It is the emptying of the lung which gets better. Thereby, there is respiratory muscle unloading and the patient is able to breathe better. It reduces dynamic hyperinflation, and we'll see the importance of dynamic hyperinflation in next slides. And what do you do? I mean, you can use either inhaled through the MDI, in which case you have to use through the spacer device because the patient cannot actually actuate the device when they are very short of breath, but you have to do multiple actuation, versus nebulizer. Now, in the studies, it has been shown very clearly that there is no difference, provided somebody can help them to take multiple actuation through the spacer device. There is no difference between different beta-2 agonists, but short beta-2 agonists are actually preferred. And should you run, if you're giving nebulizer, should you run it with air or should you run it with oxygen? You need to remember that these patients are number of times hypercapnic and they are hypoxic and they are in type 2 respiratory failure, which actually tends to get exacerbated by using high flow of oxygen. So they are dependent on hypoxic drive. So ideally you should run nebulizer in these patients on air. So the compressor nebulizer are the better rather than the source of oxygen from the central source basically. In intubated patients also, it has been seen that the inhaled bronchodilator through the MDI is a better measure as compared to nebulized, and it has been proved by Rajiv Dhand in a number of studies from PGI Chandigarh. There is no role of long-acting beta-2 agonists in these patients like formoterol or all other things. So you must use short-acting beta-2 agonist. If the patient is showing incomplete response, then ipratropium or anticholinergics are added. Methylxanthines again are added, which are optional. You need to decide whether the patient got severe exacerbation. Sometimes you can start from the very beginning. If the patient has been on methylxanthine from the past, then you don't need to give a loading dose. You just start with the maintenance dose, which is 0.5 milligram per kilogram. Otherwise, you give a loading dose of 250 to 500 milligram over a period of 10 minutes. What does it do? Methylxanthines, it causes smooth muscle relaxation, improves diaphragmatic strength. Frankly speaking, the problem is that you need to monitor this drug very severely, simply because it can give rise to a lot of toxicities, especially because these patients are elderly. They may have comorbid conditions like ischemic heart disease, where the incidence of arrhythmia can be very severe. So do I need to give steroids? Now, had it been asthma, there is no question asked. You need to give steroids. But what about steroids in COPD? In stable COPD, there are a number of studies like ISOLD and Copenhagen studies which clearly tell you that if you use inhaled steroids in stage 3 and 4, they certainly decrease the incidence of acute exacerbations. But what happens in acute exacerbation itself? Now, there are 10 good quality studies since 2005 which actually tell you that steroids do shorten the recovery time in these patients. They have significant improvement in dyspnea and ABG. The hypoxia actually improves faster, though there is no difference in mortality. And there is, of course, you need to remember that when you use these drugs, there is increased likelihood of adverse effects, especially the hyperglycemia. So what do? You do need to use them definitely, but remember, you need to wean off quickly. It is specially recommended if the FEV1 is less than 50%. The dose is 30 to 40 milligram of oral prednisolone if the patient is able to take orally, otherwise intravenous, given for 7 to 10 days only, and not for a long time. There is no role for mega doses of steroids, something which we see in some patient practicing 125 milligram methylprednisolone given every 6 hours. Certainly there is no role. It gives rise to more side effects, gives rise to more psychosis in these patients, frankly speaking. Now, do I need to give antibiotic to these patients? Again, if you remember asthma, not many patients in asthma need antibiotics. Whereas in COPD, more than 50% patients have got infective episodes. It could be viral or bacterial, but it has been said that patients who got severe stable COPD tends to get more infective episodes as compared to patients who got mild COPD. So if you have a severe exacerbation, which means that you have increased dyspnea, you have increased sputum volume and sputum purulence, all these three, clearly the antibiotics are indicated in these patients. But let's say if you just had 2, which means you had sputum purulence, but you had either one of them, either increased dyspnea or increased volume. So if you had either of the 2, then also you need to give antibiotics in these patients. But obviously any patient who's requiring non-invasive ventilation or requiring invasive ventilation clearly need to be on antibiotics. And in all these patients, you must in the beginning send a sputum culture and as well as do 2 blood cultures. Now, what is the likely organism? Now, it has been said again that if you have mild disease, you tend to have bugs which are most sensitive, which are like strep pneumoniae, H. influenzae, Morganella catarrhalis, which can be probably treated with things like amoxiclav combination combined with clarithromycin. But when you go to a high category of patients in terms of severe, they tend to get colonized with Pseudomonas, Klebsiella, and they obviously need higher degree of antibiotics basically. This is just a chart to tell you that in these patients, if it is mild, you need to give just simple amoxiclav and combination of clarithromycin as you do in cases of simple community-acquired pneumonia. But if you have a severe disease, you need to give third-generation cephalosporin combined with fluoxetine, which is the best combination. Oxygen is an important part of COPD treatment because in acute exacerbations, especially severe one, most of these patients are hypoxic. But what is important is controlled oxygen therapy. Now, control can only be given provided you knew how much oxygen you were giving. Now, when you use nasal cannula, you need to remember that you cannot give more than 5 liters through nasal cannula. But if you use mask, especially the venturi mask, you can actually control your oxygen intake to something like 24%, 28, 35, 40, and you can go maximum of 60. But nasal cannula, when you increase rate beyond 5 liters, can only add to drying of the mucosa and produce more uncomfortable feeling to the patient and will not actually help you. So you need to have controlled oxygen. Plus, you need to remember when you give them oxygen, try and titrate them to 91, 90, 90, 91 kind of thing so that you remove the hypoxemia, but you do not allow the carbon dioxide to go up because you're killing their hypoxic drive. So you need to give them continuously, short burst of oxygen and then stopping it because suddenly the carbon dioxide went up is not a good idea because then these persons will become hypercapnic and also will become severely hypoxemic immediately. So you're actually putting them to danger. So if you start to use oxygen, you must use them continuously rather than episodically. So keep the oxygen saturation around 89 to 95%, give it continuously, that's the most important thing. But obviously, not every patient will be happy only with oxygen. You need to use what is known as ventilation of some kind, and in these patients who are in type 2 respiratory failure, we now know that NIV is the gold standard. It's treatment of choice for persistent hypercapnic ventilatory failure. So if the person has type 1 respiratory failure, no rise in CO2 despite giving oxygen, probably this patient does not need NIV. If the person has CO2 retention of any kind, then you need to use non-invasive ventilation. Obviously, you need to use non-ventilation in some situation where the hypoxemia is so severe that despite giving oxygen, it's not getting better and the person continues to get worse. But very rarely in COPD patients where they reach to a stage of hypoxemia and their carbon dioxide does not rise. It does not happen most of the time. So that's very, very rare, especially it happens, pure hypoxemia will happen in mild COPD patients with massive pneumonia. It will not happen otherwise. So what is recommended is that it should be given in a dedicated setting. You must know how to use it. People tend to feel nowadays that NIV is something which I can just start and go away. I can guarantee you if you started using it, it is labor intensive. It is much more labor intensive than the mechanical ventilation is. It needs to be monitored very carefully, especially because you need to know the limitation when it's not going to work. And you need to be really, have a clear, if it is not going to work, what I'm going to do with this patient. So what does it do? It actually reduces the intubation rates. Obviously, as compared to, there were many patients who needed to be intubated, and we know, we'll see later on, that intubation has its own problem. So it reduces the mortality, and patients who could not be ventilated because several reasons now can be managed with non-invasive ventilation. But you need to have clear-cut the relative contraindication. So any comatose patients who cannot cooperate with you have the NIV mask on the face, excessive secretions, because the minute you start them on NIV, it tends to push the secretion back. And actually patients who have probably did not have any collapse, certainly you find that one side of the lung is totally collapsed because now the patient cannot take out any secretions, they're getting dried up. If you have a pH of less than 7.1, if you have refractory hypoxemia, if you have severe tachypnea, and of course if the patient is hypotensive, don't even think of using NIV, then in that case you have to use mechanical ventilation. So when you start using it, obviously you need to remember that there are adverse effects, especially because of the mask leaks. Patient can feel very severely claustrophobic. He will not allow you to keep the mask on. And if you feel that it's going to work, you have to keep on putting the mask back again and again till the time you decide it's not going to work. And that period could be decided in your own mind. It could be 15 minutes or half an hour depending on what is the clinical situation of the patient. Eye irritation, dryness of upper airway, but the commonest effect which you see is the trauma at the bridge of the nose. Of course, some of the patients will have gastric distension, which can again become a problem in giving non-invasive ventilation to these patients. So the selection criteria has to be a very important one. Okay. So if you have moderate to severe dyspnea with use of accessory muscles, if you have moderate to severe acidosis, which is pH less than 7.35, but certainly not less than 7.1, and you have a PCO2 of more than 6, which is 45 millimeter of mercury, and if you have respiratory frequency more than 25, but certainly not beyond 35, because when it becomes severe tachypnea, then it becomes very difficult for the patient to synchronize with the NIV. It has actually reduced the ventilation rate from 63% to 21%. It has decreased mortality. It has reduced the cost and outcome, and it definitely decreases workload for the first 6 to 8 hours. So you need to know when you start using it, what are the predictors of failure. As I told you, if the pH is less than 7.25, if the patient is comatose, if the respiratory rate is more than 35, if there is asynchrony and copious, all of them are actually kind of relative contraindication. If you are experienced, frankly speaking, in our situation, I've used NIV at a pH of 7.1 also, and the patients have come out. But you need to be very is labor intensive, and you need to have a plan very clearly that in case I'm not able to manage it, ventilate these patients. What about if you did not have NIV? This is what I used to do in UK as a routine. I would use a drug called doxapram, which is a respiratory stimulant. Believe me, it's an excellent drug. It used to work in virtually all patients with CO2 retention, given in the dose of 1 to 2 milligram per kilogram. And the only problem is that when you go higher than that, then it causes a lot of arrhythmias. So when you did not have it, you could use it, not otherwise. So indication of mechanical ventilation, basically patients who cannot be managed with NIV, and the biggest problem in these patients is dynamic hyperinflation. And what happens in dynamic hyperinflation? Normally when you breathe out to a resting volume. But in these patients, before you could breathe out completely, the patient starts to breathe in again, with the result that you have stacking, which means, and before you start the next breath, you have to work against that resistance to start breathing. So your workload actually increases. This is known as dynamic hyperinflation or autopnea. And the problem is that when you ventilate these patients, you have to actually fight against it. Most of the complication in ventilation and COPD is because of dynamic hyperinflation. So you have to keep low volume in these patients, low respiratory rate. Remember, no patient dies of high PCO2. They mainly die of barotrauma, volutrauma in these patients if you do not ventilate them properly. So must remember that you keep the pleural pressures below ideally 30. Keep a IE ratio of more than 1.3. You must sedate and paralyze these patients. And use extrinsic PEEP, which is kind of paradox in these patients. But what happens with extrinsic PEEP is that you're trying to counter the respiratory muscle load, which is already there, against which you have to start the next PEEP. So if you use extrinsic PEEP, which is 2/3 of the auto PEEP, then these patients tend to breathe better. The mortality of patients who get ventilated is almost 22%. You must ventilate these patients for at least 24 to 48 hours. Unlike asthma, where you can ventilate them for 4 hours, patient is fine, wheeze is broken out, take them off. But these patients you need to give rest so that they get better faster. And some of these patients may need NIV. Don't forget other measures, which means fluid administration, nutrition, because some of the patients are nutrition poor, prophylaxis for deep vein thrombosis. You need to remember sputum needs to be cleared. The patient may need good physiotherapy. And manual or mechanical percussion needs to be done at times to do that basically. There's no data to support N-acetylcysteine in these patients. These are some of the things which are unconventional, which can be used. Heliox reduces the resistance of the gas, so it works better in NIV.